story of what happened to them 30 years ago. So we're going to be checking them head to toe real quick, hands on where appropriate. All right, so sir, up inside your head now, are you having any lightheadedness, dizziness, anything feel weird? No? Okay, any drugs or alcohol today? I know, silly question, I ask everybody. No? Fantastic. Okay, open up your mouth. Good? No issues? All right, now how about down in your neck? Go ahead and swallow for me. Fantastic, thank you. Go ahead and sit forward for me. I'm going to take a listen to your back. So we have the patient sit forward. We're going to go ahead and listen to our lung sounds. This is a heavy mannequin. So 1, 2, 3, 4, 5, 6. We're starting very low. Here's where we're actually listening for good appreciated lung sounds. I want to know rales, wheezes, rhonchi, diminished, clear, anything like that. Okay, your lungs sound nice and clear. Are you having trouble breathing? No? Fantastic. How about up in your chest? Go ahead and take a nice deep breath for me. Good. In your chest, are you having any pressure, heaviness, tightness, anything like that? Anything abnormal today? No? Okay, fantastic. Now, moving down into your belly, can you tell me where it hurts? Okay, right here. All right, now I'm going to start from away from there. I'm just going to press real quick, okay? Very good. Okay, I'm sorry. Yeah, hurts there. Very good. Okay, anything else besides the pain there? Okay, and any blood in your bowel or bladder? Now, when you have when you urinate, bowel movement? Okay, any nausea or vomiting? Okay. How about down in your hips? Any issues there? No? How about your legs? Do your legs feel funny? Any issues going on today? No? Good deal. Can you wiggle your toes for me? Fantastic. How about up in your arms? Any problems that you've been experiencing recently? No? Good deal. Go ahead and squeeze my hands, please. Fantastic. Done. That was a rapid medical assessment. Now, what did I just check? Okay, so what I just checked was this. What I was trying to identify here is, just like on my rapid trauma assessment, trying to find anything that could potentially kill my patient or is an ominous sign of something that's developing. I'm looking for the same kinds of things here. So when I come up to the head, I'm looking for any neurological deficits, any neural problems. I'm also looking for psychosocial issues, okay? And I'm looking for altered mentation. And I can roll all those out very easily just by asking those few questions. And I can't roll anything out 100%, but it's going to give me a red flag to investigate further. From there, what can kill me in my neck? Well, anaphylaxis. So I'm going to have them swallow real quick. If they can do that without any issue, pretty much don't have a problem there. I'm going to go ahead and have them sit forward. We're going to listen to lung sounds, which you'd be listening to for every patient anyway. Giving a good comprehensive review of our pulmonary system. Check. Done. Moving up to the anterior aspect of the chest, I'm rolling out any major issues off the top with cardiovascular. I won't get caught with that whole situation where I take an abdominal pains patient in and actually the whole time they had a chest pains problem. And the only thing that's going to mess me up now is Frank lying to me. The patient would have to completely tell me a false statement. Can't always prevent that. You do the best you can. Coming down here, I'm checking GI-GU. Finally, I've got musculoskeletal. And by the wiggling of the feet and the mini squeeze of the hands, I have done a miniature neuro exam. I'm not doing a full Cincinnati Pre-Hospital Stroke Scale. I'm not doing a race score unless the patient had an indication to tell me that that needed to follow up. If this was equal and seemed normal, okay. Also, by checking lung sounds, I have checked the posterior aspect of the patient. When I was down here at the legs, I can give a squeeze just to see if there's any pulmonary edema. So, all of these types of things is just a really quick rapid check. It's much more systematic than learning a cardiovascular assessment, then learning a pulmonary assessment, then learning a GI-GU assessment, then learning a musculoskeletal assessment, and missing a major component. So that's our rapid medical assessment. And then likewise, you can see how this carries over for our trauma patient who is a minor trauma patient. Minor trauma patient. So we had the we had the multi-system trauma patient in the previous video. This one shows you the rapid medical assessment. But understand too how you can arrive on a scene and the patient has, they're complaining of a twisted ankle. Okay, they're not unconscious. They're not laying supine. You wouldn't necessarily do what you all, are trained to do for the patient who's been ejected from a car. But my argument is you should. You should still be checking them head to toe. And here's why. At least where I work, my patients lied to me a lot. My gentleman who who did in fact call me for a twisted ankle, yeah, he called me for a twisted ankle. What he failed to tell me is that he jumped off of a 2-story window because he was trying to evade the police. Not everything is malicious, but unfortunately, once again, it's my job to protect them from themselves. For all he knows, it's just an ankle. What I know from a 2-story fall is axial loading, internal hemorrhage, a litany of issues. My job is to be there to protect my patients from even themselves. So what I'm going to do for that gentleman is, okay, sir, terribly sorry to hear about your ankle. Listen, just going to check you out head to toe real quick before we, as my partner goes get a pillow and put a splint for your ankle. All right, so, and then we move into hands-on, over top the clothes. Unless it's super bulky, then we're going to disrobe a little bit to just get a good assessment. And we're going to be checking everything. We're going to check head, neck, chest, abdominal, pelvis, legs. There should not be any surprises when you get into the emergency room. And if the story wasn't matching, here's where you find it. Because our patient can tell us a lie. Whether it's because they're lying to themselves or they're purposely lying to us, no matter. Or they could be not even lying to us, they could just be telling us the truth because their belly really hurts. It's 10 out of 10. But that might not be what's going to kill them. What's going to kill them is the chest pains that's 4 out of 10. So all day long they're telling you about the belly. You could spend the whole transport talking about the belly. You could know everything about their colitis and how many times they've been to the doctor and which specialist they have. And the fact that your cousin goes to the same specialist. None of it matters if you miss this. What they can't lie about is when you assess everything. You assess it well enough that complaints are elicited even though they don't necessarily want to admit it to you. So that's your rapid medical assessment. Once again, as soon as we are done with this, we can move into the other elements of our secondary assessment. Now, they fall on equal planes as well, just like our primary assessment is not airway, breathing, circulation, disability, exposure, but it's actually like this, okay, the horizontal. Our secondary assessment is the same. You have either a rapid medical or rapid trauma, which falls in line on the same plane with a full set of vitals, also a sample, and an OPQRST, all of these together. From here, we can form a differential diagnosis, and then we have a good qualifier for knowing how often we reassess. So that concludes, for the most part, our universal patient assessment. The one caveat I will tell you is that in drafting up this document, in creating this training profile, it's right here, you'll notice that there's a small exclaimer right here, which simply says some patients may require a rapid trauma assessment and a rapid medical assessment. And then it will be up to you as the clinician to decide which one takes priority over which one. And that's pretty simple. That's going to be the type of patient who it's chicken and egg situation. Yes, they were involved in a motor vehicle collision. Why? Did they go unconscious? Yes, they went unconscious. Did they go unconscious because they struck their head, or did they go unconscious prior to the collision causing the collision? So you have a medical issue that has caused a trauma scenario. Why did they fall down the flight of steps? Did they actually trip their foot on the carpet? Or is it because they got lightheaded first? That kind of a patient is going to need a full trauma assessment and a rapid medical assessment. They're going to need rapid trauma assessment and rapid medical assessment. So be aware of that. Be smart, be safe, do a good job protecting your patients, and you'll be great. Until I see you guys again, love, protect, and help.